19-year-old girl with a history of immune thrombocytopenic purpura managed by systemic corticosteroid presents with a 3-month history of bruising, acne, and weight gain. She reports that these symptoms progressively worsened until she discontinued her corticosteroid therapy 4 weeks ago. This week, she began to notice multiple bruises all over her body. Vital signs are within normal limits. Physical exam reveals multiple petechiae and superficial bruises on her torso and extremities bilaterally. Moderate truncal obesity and mild posterior cervical adipose deposition is noted. Multiple deep comedones are present on the face and upper torso. Which of the following is the most appropriate next step in the management of her chronic ITP? Transplantation of stem cells, administration of IVIG, continuation of systemic corticosteroid therapy, splenectomy, or transfusion of thrombocyte. Again, here there is a condition ITP, immune thrombocytic purpura, and the patient is already on steroids since a long time, and now the patient developed acne, weight gain, and all of those classic things that you see in chronic steroid use. So the patient stopped taking steroids, and now the patient is presenting again with multiple bruises. So they're asking, how are you going to manage her ITP now, her chronic ITP? So the answer here is splenectomy, because chronic ITP the patient has, and now there are manifestations of chronic steroid use like truncal obesity and posterior cervical adipose tissue, and which is obviously making this patient uncomfortable. And not just these physical findings, but there are a lot of metabolic changes too because of chronic steroid use, right? Like hypoglycemia, and there is damage to the bones, weakness of bones, which especially in this age group is harmful. So steroids, continuous steroids use for any condition we try to avoid. Usually in ITP, we give one course of steroids, and what happens is there occurs a remission of ITP and there are no more symptoms after stopping steroids. But here the patient abruptly stopped steroids, but even after the course of steroids, the ITP is still manifesting. So we have to think of an alternate treatment option here, which is splenectomy. Why splenectomy? What is ITP? ITP occurs when these are the platelets, there occurs an antibody formation against these platelets. Now these platelet being the antigens and the antibody, antigen-antibody complex go in the spleen. Okay. These are the platelets, these are the antibodies. These antibody complexes go in the spleen, where in the spleen there are phagocytes which will consume these antigen and antibody platelets, right? So the problem here is with the spleen. It is because of spleen that the destruction of these platelets is occurring. Otherwise, everything is normal. There's normal production of platelets, and function of platelets is also normal here. It's just that these complexes and subsequently these platelets are being removed in the spleen. So after doing splenectomy, there will not be the disappearance of these antibodies. They'll still be there. So, but the only thing is the platelets will not be consumed by the spleen, and so it will not lead to a decrease in the number of platelets and subsequent bleeding due to this thrombocytopenia. That's why splenectomy is a treatment of choice for chronic ITP. Now, let's take a look at the other options. Transplantation of stem cells. It will not be useful because there is no problem with stem cells here. The stem cells are normal in this patient. It's just that the mature platelets are getting destroyed. So a transplantation of stem cells will not be useful. Now, administration of IVIG. Now, what's the function of administration of this IVIG? We can use this IVIG in an acute episode to stop the platelets from being destroyed, but it is not a long-term treatment. I think a lot of you chose this option. The thing with IVIG is it's not a long-term option. You cannot keep on giving them IVIG, which is not feasible. Splenectomy is a much better option. Now, how does IVIG work? IVIG is immunoglobulin. given externally. So what these immunoglobulin does is it goes and binds to these phagocytes on the in the spleen, and they will bind to the Fc receptor of these phagocytes. Now, usually it is this is the Fc portion, right, of the antigen antibody complex. So this Fc portion of this platelet antibody complexes binds to this phagocyte and they are consumed. But what this IVIG does is it goes and binds to this Fc receptors and will saturate these Fc receptors of the phagocyte. So they will not be able to bind to this antigen antibody complexes anymore. And that's how it will prevent the destruction of platelets from happening. This is not a long-term option, it's not feasible. Transfusion of thrombocytes, it is also not, doesn't make sense, right? Even if you transfuse all the platelets in the world, but the antibodies are still there. Whatever platelets you transfuse, the antibodies will bind to those platelets and cause destruction within the spleen. So it's not an answer. It is spleen, which is the source of all these problems. And so removing spleen is a treatment option in chronic IDP.
Thanks for watching. Please give a thumbs up and subscribe for more.